Good morning. In the previous class, we have discussed the classification of corticosteroids, the mechanism of action of corticosteroids, the effects of corticosteroids on different organ systems, and the uses. In today's class, we will discuss the adverse effects of corticosteroids. You are familiar with this term, Cushing syndrome, from your first year physiology class, which is characterized by moon face, buffalo hump. There is a centripetal redistribution of fat. The skin becomes thin, leading to red striae. Because of the thin skin, easy bruising and ecchymosis. Arms and legs become thin. There is osteoporosis, compression fractures of the vertebrae. Now, system-wise, what are the adverse effects? On short-term use, corticosteroids cause, especially on oral administration, nausea, vomiting, anorexia, epigastric distress, acute erosive gastritis with hemorrhage. Now, this can be explained in terms of the inhibition of prostaglandins in the stomach. On long-term use, corticosteroids can cause peptic ulcer and pancreatitis. On the cardiovascular and renal system, because of the effects on blood volume, sodium and potassium balance, the following things happen. Hypertension, because sodium is retained, potassium is excreted, blood volume increases, therefore there is hypertension. There is salt and water retention. Hypokalemic alkalosis. Remember, corticosteroids cause potassium loss and sodium retention. On the CNS, the effects are mainly because of the imbalance in the electrolytes. Mild euphoria, nervousness, insomnia, mood changes, and in rare cases, psychosis. On the musculoskeletal system, it's called proximal myopathy. That is, the muscles of the arms and legs become thin because of the negative nitrogen balance. Osteoporosis because of calcium resorption from the bones and increased renal calcium elimination. This results in avascular necrosis of the bones, especially of the lumbar vertebrae. This happens with long-term use of corticosteroids. Now, what do we mean by long-term use of corticosteroids? When 20 milligrams or more of prednisolone is given for more than 2 weeks duration, there is a risk of hypothalamo-pituitary adrenal axis suppression. If the corticosteroid after a 2-week duration of treatment is suddenly stopped, there is a risk of acute adrenal insufficiency. This is because the externally administered corticosteroid by negative feedback suppresses the hypothalamus and pituitary. Therefore, the adrenal is not stimulated to produce corticosteroids, and when it is suddenly stopped, the adrenal is not able to produce enough corticosteroids. So there is an acute adrenal insufficiency, also called acute Addisonian crisis, which is a medical emergency. So one way to prevent this acute adrenal insufficiency from happening is to taper the dose and stop. That means gradually reduce the dose over a period of another 2 weeks and then stop. This is an example for a type E adverse effect, that is end of use. A drug given for a long time, if it is suddenly stopped, results in an adverse effect. Now there are a few methods to reduce the risk of hypothalamo-pituitary axis suppression. One is give the dose of the corticosteroid early in the morning, that is between 3 a.m. and 5 a.m. The hypothalamus and pituitary are least sensitive to negative feedback during this part of the day, that is between 3 a.m. and 5 a.m. So if a person or a patient is required to take corticosteroid for a long duration, it is advisable to administer the corticosteroid early in the morning, between 3 a.m. and 5 a.m. because the hypothalamus and pituitary are least sensitive to negative feedback inhibition. The other method of reducing the risk of HPA axis suppression is to give the doses on alternate days. So the adrenals are also able to produce some amount of corticosteroids. Then the third method of reducing the risk of HPA axis suppression is what is called mega dose pulse therapy. That is, a large dose of corticosteroid is given for a short duration of time in what is called pulse. That is, for example, in situations like Stevens-Johnson syndrome, traumatic optic neuropathy, to prevent organ transplant rejection, methylprednisolone 5 mg per kg body weight per day is given for just 3 to 5 days and stopped. This also prevents or reduces the risk of HPA axis suppression. And among all the corticosteroids, using prednisolone is least likely to cause HPA axis suppression. Excuse me. So these are parts of a 3-mark question for you. Give reason. Early morning dose is preferred for long-term treatment with corticosteroid therapy. Or give reason. Prednisolone is preferred for long-term use of corticosteroids. The reason is these methods are least likely to cause hypothalamo-pituitary adrenal axis suppression. What is this mega-dose pulse therapy? This is a 3-mark question. Mega-dose pulse therapy refers to high doses of a corticosteroid administered over a short period of time to overcome the risk of HPA axis suppression. So here methylprednisolone 5 to 20 micrograms per kg per day given intravenous for up to 5 days. So this is the mega dose given once a day for up to 5 days. Some of the indications for mega dose pulse therapy include Stevens-Johnson syndrome, Guillain-Barré syndrome, pemphigus vulgaris, cerebral edema, traumatic optic neuropathy, organ transplantation, that is to prevent rejection of an organ transplant, ulcerative colitis and angioedema. Along with megadose pulse therapy, prophylactic proton pump inhibitors should be given, like omeprazole, pantoprazole, because remember, omeprazole, pantoprazole are proton pump inhibitors which block acid production 100%. Corticosteroids, by inhibiting prostaglandin synthesis in the stomach, predispose to peptic ulcer. Why prophylactic antibiotics? Because corticosteroids are immunosuppressants. There is a risk of secondary or super infection. On the eyes, if corticosteroids are used topically for a long time, there is a risk of glaucoma and risk of cataract if the corticosteroids are administered systemically over a prolonged period of time. The metabolic effects. Remember, corticosteroids are diabetogenic, very important. Blood sugar levels increase, therefore predisposes to diabetes mellitus. There is retardation of bone growth when given to children. Remember, corticosteroids resorb calcium from the bone. Therefore, if given to children over prolonged periods, there can be growth retardation. If given during pregnancy, studies have shown that corticosteroids are teratogenic in experimental animals, resulting in intrauterine growth retardation. Behavioral and neurological changes can also be seen. So it is advised to exercise extreme caution while using corticosteroids during pregnancy. Because of immunosuppression and anti-inflammatory action, there is a risk of secondary infections and wound healing with delayed wound healing. On topical application, corticosteroid ointment, prolonged application over a specific area of the skin becomes thin, easy bruising, ecchymosis, that is bleeding under the skin, atrophy of the dermis, like we mentioned earlier, easy bruising, delayed wound healing, bacterial and fungal infections. These are because of local immunosuppression. There can be secondary infections. The contraindications for corticosteroids. Peptic ulcer. The reason? Decreased prostaglandin production in the stomach, therefore decreased mucus production, predisposition to peptic ulcer. Diabetes is a contraindication because corticosteroids increase blood glucose levels. Corticosteroids are diabetogenic. Hypertension, because of salt and water retention, increased blood volume, hypertension. Tuberculosis. Tuberculosis is an infectious condition. So if corticosteroids are given, there is a risk of secondary infections, and this can lead to flaring up of even latent tuberculosis. But there are some exceptions which we will describe later. Osteoporosis. Corticosteroids cause negative calcium balance. There is calcium resorption from the bones and increased calcium excretion by the kidneys. Herpes simplex keratitis. So if there is a viral infection of the cornea, if a corticosteroid is used, local immunosuppression can cause secondary bacterial infections. Psychosis, again, because corticosteroids by themselves can cause psychosis. And epilepsy and congestive heart failure. Epilepsy because of the changes in electrolytes. Congestive heart failure because corticosteroids cause fluid and water and sodium retention. It can further worsen congestive heart failure. Now, what are the general principles or precautions to be taken before, during and after corticosteroid therapy? This is a 5-mark question. What are the general principles of corticosteroid therapy? Before starting treatment, inquire about and check for peptic ulcer, which is a contraindication, diabetes mellitus, which is a contraindication, tuberculosis and other infections. During therapy, the drug is to be taken with food to reduce gastritis. Advise a low sodium, high potassium diet because corticosteroids cause sodium retention and potassium excretion. Check blood pressure, weight, blood glucose and ocular changes. Increase the doses in case of stress. Patient may need proton pump inhibitor, vitamin D, calcium and maybe prophylactic antibiotics also. Instruct the patient not to stop therapy abruptly because there is a risk of precipitating acute adrenal insufficiency or acute adrenal crisis. Stopping therapy, taper. That means gradually reduce the dose. If it is stopped suddenly, there is a risk of acute Addisonian crisis. Especially if the patient has taken corticosteroids for 2 or more weeks at 20 milligrams per day of cortisone. Okay, so please remember long term. When we say long term treatment, if a patient has been taking corticosteroids for 2 weeks or more, it is advisable to taper the dose, not to suddenly stop. Now, acute Addisonian crisis or acute adrenal insufficiency is a medical emergency. This is a 5-mark question in both pharmacology and general medicine. So, acute Addisonian crisis is characterized by fever, hypotension, muscle pain, feeling of weakness and joint pain. Treatment comprises of the following steps. Intravenous hydrocortisone 100 milligrams bolus stat. Immediately give hydrocortisone 100 milligrams intravenous, followed by hydrocortisone 100 milligram infusion 3 times a day, IV fluids, antipyretics to reduce the fever. If the blood pressure is very low, vasopressors like dopamine, dopamine may be needed. If you have any questions, you are welcome to ask. Thank you.